I'd like to welcome everybody who's joining us tonight. A quick update before we get started. This week, Blue Sky Bio released a touchless operation mode for Blue Sky Plan, enabling you to actually operate Blue Sky Plan without touching your computer or mouse. Details on the Blue Sky Bio website, and we encourage everyone to check it out and give it a try. A few months ago, Blue Sky Bio released BioCut, our direct cut drilling solution, which is a complete guided surgical solution in a single drill. No need to buy a guided surgical kit or use tubes and sleeves during the guided surgical process. Tonight, we have the privilege of hearing Dr. Darren OBrien explain and present the use of the direct cut drills using the conus 12 implant and the Sicat Optiguide. I don't think Dr. OBrien needs much of an introduction, but Dr. OBrien was one of the first dentists to use CEREC Guide clinically, is an internationally published author, and speaks nationally and internationally on the use of CAD-CAM with integration of CEREC and the cone beam CT. Dr. OBrien?
All right, thank you, Michael. Good evening, everyone. So, first off, thanks for coming out tonight and sitting in on this webinar. I know it's holiday season time, and there's probably parties going on that you'd rather be at, so thanks for taking the time to listen to this webinar. So tonight we're going to talk about the Sicat guide with the direct cut drills and what this offers to the clinician as far as ease of use, efficiency, to increase our productivity, the response for our patient, and the overall experience for our patient. So a little bit about myself, first off. Dr. Darren OBrien. I'm faculty at CEREC Doctors. I am an advanced trainer for Patterson for the CEREC technology and also for the cone beam. I'm a beta tester, product evaluator. I have a private practice in Coos Bay, Oregon. For those of you that don't know where that is, you may have heard of Bandon Dunes. It's a very well-known golf resort. That's about 20 minutes south of me. So I'm kind of in the middle of nowhere. The nearest Target store is about 90 miles away, so that tells you kind of how desolate we really are. Beautiful area, but it's a small town, about 25,000 people. I've been doing implant surgery since 2005. I had my cone beam around 2009. I use it every day on my patients for diagnostics and also for treatment planning of my implant restorations. What I'd like to do tonight is I'm going to talk about the direct cut drills and how I've been utilizing these since they were released. The idea with this is that one drill with the proper topography can do all of your osteotomy, and there's a number of research papers out there now that support this by using thermal testing in the bone as they're drilling, that a single osteotomy, even at the final drill size, generates the same or even less heat than doing sequential drilling. So the advantage here is we don't have to drill as often. I mean, patients don't really like us taking a drill to their head, so the less we have to do, the happier they are. It also allows for quicker procedure as well, because we're not having to switch out keys and switch drills and everything else. And, you know, previously the reason why we were doing sequential drilling is, one, we thought that it caused a decrease in the amount of heat generated, so you would not get bone necrosis. And the other was so we could take an orientation x-ray. Well, now with 3D imaging and the ability to create accurate 3D guides, we no longer need to check our orientation. That's been predetermined in our planning through our planning software. So the first thing that's going to happen is you're going to get your surgical guide created. You're going to do a CT scan, and in this case, you can see we've incorporated the CAD-CAM design in the lower left-hand quadrant for replacement of tooth number 20 on this patient. We're going to use the Sicat guide here, specifically an Optiguide in the particular cases I'll be showing later. And then we take the CT scan. We are going to designate it currently as the AstraTech system because the Blue Sky system is not in, for the conus, is not in there. What you would do in the Sicat software is pick whichever compatible implant system you're using. So if you're using a Zimmer compatible, you'd pick the Zimmer compatible. You would pick the Zimmer implant in the Sidexis software. So we're using the conus 12, replacing a 4011 in this situation. So you can see we just picked the corresponding implant that's compatible with it. So once we have that, we're able to create our surgical guide. Now, historically, guided surgery is somewhat of a pain, obviously much nicer than freehanding it. However, you've got the guide you have to stabilize. You've got the key in there. Well, now that used up your two hands. So either your assistant's holding something or you're trying to hold down the guide, hold the key with one hand, have the drill in the other hand. We're not talking now. We still have to retract. We still have to keep light on it. Now, if you're using a headlamp, obviously that's easier. But you needed about 6 to 8 hands to really do implant dentistry, you know, a little reflecting the flap and everything else. So the idea here is let's take one of the hands out of the equation. Let's not get the key involved. We can remove the key and have that attached directly into our guide. Then we don't have to worry about it. We don't have a second piece that we have to monkey around with. This also is much easier, especially as we start to try to do implants in the posterior region where you may not have the best access. You've got the cheek in the way, the tongue in the way. There may not be a good way to get the key back here. I used to use the Facilitate system from Astra, and the problem with it was the keys were very small and not real easy to handle. So as you start to go posterior, you have your hand back in the mouth trying to get the key to engage, and then you've got to try to get your drill in there. And it was just, it's much harder to do. So the idea here is we're going to have our guide, and then we're going to have a keyless tube that gets glued into the surgical guide. Now, if you're doing a sequential drilling, you really can't do this. You have to pop out the guide, the tube from inside, and re-cement the next guide. So it really only is possible when you're using the final diameter for your osteotomy, something somewhat like canal used to do. So here we've got our guide, our key, and our tube that's in there. So the tube replaces the key that we would normally utilize. And then you can see we have a printed stop, which is represented by the blue, that is printed out and attached onto the shank of the drill, and that acts as your various guide, or as your drill stop, so that you can judge your depth. So at this point, your angulation, both mesial-distal, buccolingual, is determined by your placement, and your guide is going to control that, and your depth is controlled by this drill stop. So the tube is 1 millimeter thick. It is going above the guide. So now your total length from the top of your implant when you order a Sicat guide is going to be 9 millimeters plus the 1 millimeter tube. The 9 millimeters is standard, and then the 1 millimeter guide tube, which replaces your key. So you're going to be 10 millimeters from the top of your implant to the top of the tube. So we'll take that into account as we start figuring out lengths, and I'll show you that in just a second. And that is standard. When you order the Sicat guide, you're going to order the Nobel compatible 5 millimeter master tube. Now, we're using the Astra system. You're still going to order the Nobel 5 millimeter master tube. So you can see on this slide that there's the Sicat guide, and the guide tube goes into the various tubes. Now you'll have one guide tube for each hole. So as you can see in this situation, we have the 4.0 Astra implant, but as you go to the ordering the surgical guide from Sicat, you're going to take the drop-down menu and you're going to go down to Nobel Biocare. And you can see it's going to bring up the drop-down menu. You go to Nobel Biocare, even though you're using an Astra implant, or in this case the conus 12, you're using the Astra compatible. It's going to give you this warning. The chosen sleeve system is not compatible with all planned implants. That's okay. We know it is, so just hit OK, and then that's going to send the guide to Germany, and you don't have to. They will then put in a Nobel 5 millimeter guide tube. Any questions on that? And Michael, you're going to send questions my way, correct, if anybody has any?
Yeah. Right now there are no questions.
Okay. So when you go to order the implant, if we're looking at the 3.540 platform here, you can see that we have for Nobel compatible 5 millimeter master tube, and in this is under the guided implant section on the Blue Sky Bio website. You'll see that the price includes the tube. So what you'll get now is instead of just the implant, the healing abutment, and the cover screw, you will also get the guide tube that you need to put into your Sicat guide. So all of this comes together. Then at the bottom of the screen, you can see guided surgical stop STL files. So when you order your implant, what you would do is, let's say we're going to get the 3.5 millimeter, 13 millimeter long conus 12. I'm going to go down and I'm going to download the STL stop for the 13 millimeter long implant. That is a downloadable STL file. You can then take that to any laboratory with a 3D printer for plastics, and they can print out your drill stop. Now, there are some labs that are on the website as well, Road Dental being one of them, that can print them for you. If you just want to call them up, they can print up a batch of the various lengths and send them to you with about $5 worth of shipping for about as many, because these things don't weigh a lot. And as you can see, most of these are for the long drills. However, if you look, the 8 and 9 millimeter long implants also come in the short drill, which is really handy when you are trying to place an implant in 19 or 18 on Mrs. Smith, who can't seem to open past about the width of a fork. So you don't have to try to get the long drills all the way back in Mrs. Smith's mouth now. You can utilize a much shorter drill length to at least start the osteotomy and get the initial depth. If you can't, if you need something longer, great. You can always transition to a longer drill set later if necessary. But for the short implants, the 8 and 9 millimeter implants, you do have the option of getting a drill stop for those shorter, drills. All the rest of them are on the long drills, and they fit right over the shank of the drill. Now, each of these tubes also has a notch in it. Now, that notch will allow you to then orient your internal connections if you want. So if you're using something that has very easy to note internal connections, you can have that placed with the notch oriented to the buckle if you want. And here's a close-up picture of it. You can see there are some bevels on the inside, on the outside of the tube, so that helps engage the cement a little bit to lock it into place. And then there's the notch right towards the facial. So this 1 millimeter high lip, you can see, sits over the top of the implant, or over the top of the guide tube. This is going to then, that tube corresponds to, like I said, whatever your final diameter is. If you're using a 3.5, that tube is going to be the final drill for the 3.5 millimeter implant. So you can go up to the 5 millimeter implant with just the 5 millimeter Nobel for the conus system. So with any of these, you're always going to have the exact same guide tube. You don't have to change the tube that's inside the Sicat guide. You just have to change the insertion tube that you get from Blue Sky Bio. Now, as you see, it also sticks out about 1 millimeter below. Like most keys, it's 5 millimeters in length. So it will take into account if you're trying to program these for, say, like a Sicat guide, which we can get into at a later time. And here's the guide, the drill stop placed on the drill. So each drill stop is based on the length of implant. And you can see where the green starts is where it's going to end up sitting flush with your surgical guide. So when you order a 13 millimeter implant, you're getting a guide. The stop is going to be up about 24 millimeters, because you're going to end up having the 13 millimeters of implant and the 10 millimeters of space between the top of the implant and the top of the guide key and tube. And here it is all put together. As you can see, there is our guide tube, there is our Sicat guide and the drill with the drill stop, and you can see how the drill stop slides over the top of the shank. So that's the whole process put together, making it very, very easy for you to just go in with a single drill once you have your particular planned implant situation. So let's take a look at a couple of case studies here, and I'll walk through each one and discuss them at length so you can see exactly how this all puts together for a case. So here we have an edentulous patient. We had extracted a tooth and grafted the site. Now in this situation, we had plenty of keratinized gingiva to work with, so it's very easy to be able to just go in and do a punch technique in this situation. And what I will do is since I know I've got a 5 millimeter tube, I take my tissue punch and I go right through the tube there. Now, if you've already cemented your guide tube inside of the Sicat tube, then you can just mark it with an Explorer or a perio probe just to get the spot centered, and then you can cut it outside. But I actually just do this, and then I cement the tube in right before I do surgery. So there's our guide with the tube in place. And you can see the little bit of resin cement that I utilized to just lock that into place with the inside the guide. Now the beauty of this is it's very, very stable. It doesn't move, and you can see the guide sits on top of the teeth, so it locks into place. So now that's completely free. I only need my one hand to utilize my drill, and that's it. I don't have to worry about, so if I was reflecting a flap, my other hand can help reflect the flap if I'm not able to get my assistant to be there in that situation, if it's on my side and it's harder for her to reach. So I've got a free hand here to work with whatever I want, which makes it very, very convenient. Then we place our drill in, and you can see the angulation, and you can see where the drill stop goes. And then we drill all the way to depth. One shot, done. Nothing else except a slight pumping action. So you do, once you break the cortical plate, you will find that it goes very, very quickly. Make sure to, when you're doing this, because the intimacy of the guide, make sure to pump just a little bit as you're drilling. That's going to allow the water to hit the drill and help cool that off to create a heat sink so that, again, you're not overheating the bone. Even with the one drill protocol, you still need to utilize a good amount of copious irrigation to keep from overheating the bone. But just make sure you use a pumping action, because the guides, this isn't any guided situation. What you have to worry about is the water's not going to get down there unless if you have an internally irrigated drill, which these are not. So you have to make sure you are pump actioning it a little bit to make sure you are cooling everything off as you're doing it. And once we're done with that, we take the guide out. You can place most of the implants through the tube, but realistically, they're not fully guided anyway, so I just place them freehand. I figure if I can make the hole in the head, I can probably place the implant in there without too much of an issue. So then we place our implant, and as you can see, the implant is in place. We place the healing cap on, or the healing abutment on, and there's our final. Now, if you're wondering about the accuracy of this, what I did in this situation is I actually had the drill go all the way to just at the sinus floor, just enough to thin it out. I then used the implant to slightly fracture that and bump the sinus up a little bit without actually having to pack any bone in there. And we were able to do so very, very easily. And there's the plan and our final implant plate. You can see it mimics it perfectly. I was able to get a little bit more depth once I fractured the plate a little. So that was an edentulous site. Now, a healed site is very, very much, or a extraction site is very much the same. We're going to plan out our implant. You can see we're going to be kind of snug up against that, against the canine. This patient had a root canal tooth that had gotten recurrent decay underneath it. It was pretty much bombed out. There wasn't a whole lot we were going to be able to do with this. So we've got our guide. We put our tube in there. Now this is shown off of a model. We extract our tooth with periotomes. Of course, the tricky part here is every single time we touch the thing, the root canal tooth just disintegrated on us. So we had to very, very carefully get this thing out of there with some periotomes and root fix. But there's our guide in place. Now, again, we don't have a flap to reflect, so we're actually in a much better situation than we normally would be. And a lot of times with these situations, with these cases, even if you are flapping, your guide can actually hold the flap back. If there's an extension on it, it'll hold the flap. As you can see right there by the canine where the guide kind of dips down, a lot of times your flap will be held back by the guide itself. If not, what I highly recommend is just taking a suture, the patient's numb, take a suture and suture that to the cheek or tie it off somewhere so that you don't have to worry about it anymore. I've even taken it and tied the suture to the flap and kept the string long and wrapped a hemostat around it and hung that off the side of the patient's mouth just a little bit. Or you can even clip it onto the patient's bib or something else so that it keeps the flap out of the way. That just gives you one less thing that you have to manage, making it very, very easy, again, when you have a situation like this or a system like this where you're not having to have multiple hands in there all the time. And then we take our guide. Now, in a situation when we've got a case like this with an immediate extraction, you know, one of the biggest problems when doing an immediate extraction case unguided is you're going to kick down the roots, especially in a multi-rooted tooth. This case was not done. This case was done a few months ago, but I just did a case the other night with this utilizing a Sicat guide where I had a bifurcated upper bicuspid, and so I wanted to put the bone right in the furcation area, and I was able to do so with this because it guided the drill right through that furcation area and it was only one drill to start to finish. We were able to actually split the two routes and go down the furcation area now. So once we go to depth, and then there's our placement of the implant. Now, it looks like it's a little more snug on the design than what it was in the previous. However, what happened here is it's just the patient, when we tried to place the PA X-ray in there, it was pushed distalized, so it ended up snugging it up against the canine. But we get a very, very quick placement of the implant. Now, most of these surgeries are taking under a minute start to finish, because once I've got my punch, I'm only going to have to go in with one drill. Now, sometimes with these, what you'll see is the cortical plate is fairly dense in a healed site. And when that occurs, the large drill may not grab that very well. So what I will do is I will a lot of times go in with a round burr or even a small starter punch, a pilot drill. Just break the cortical plate. All you have to do is have a hole in the cortical plate, and that will be enough to get the drill to catch. And then once that happens, it just eats right through the cortical plate. At that point, then you can go to depth after that. Otherwise, it requires a little bit more pressure if you're trying to actually break the cortical plate with the final drill. So I recommend once you have placed your surgical guide, just take a small round burr, make a small perforation in the cortical plate, and then your single cut drill will grab that much easier. And that'll produce the final osteotomy for you. So in this case, we had a patient that had two failing root canals, and we ended up, he had these for a while, so there was some destruction of the cortical plate. So we extracted a teeth very, very carefully, and yet we still had fenestrations and dehiscences. So we placed graft material. I was not willing to do this one as an immediate case just because I did not like the way that buccal plate was and the amount of infection that this patient had in these sites for so long. So after we had grafted, we let it heal, of course, and there's our healed site. Now, this is a case you could approach a couple of ways. You could go in with a punch, or I saw something on the CT scan that made me look at it with a little more hesitation. The left side, site number 9, had what appeared to be even just a thin part of cortical bone, and that's where we had the most infection, and the cortical plate was not real solid. So I was a little concerned that I was going to end up with another fenestration in there as we went along. So I went ahead and flapped this case to make sure that I could see the bone a little bit. I really like to see where I'm going to end up with. Now, this case was planned out on the CEREC. We incorporated 2 anterior crowns. I then exported those to the Galileo software and planned out exactly where my implants were going to be. Now, this patient also has the added benefit of not only having some massive infection in there when we started, he also has an incredibly large incisal canal. So I had a couple of options here. I could have placed probably 4.0s, maybe even 4.5s here, but I would have been into the incisal foramen fairly solidly, and I just didn't want to do that. Even going down to the 3.5s, I was going to end up with problems of running into the incisal foramen. So I knew I was going to have to clean it out, but I wanted more of my implant locked into bone if I could, and he's got kind of small teeth to begin with, so there wasn't a lot of dental space between the two laterals to be able to place multiple implants in here. So I went with the 3.5s, and because we were doing a 3.5, we ended up I wanted to go a little bit longer just to make sure I had plenty of implant to help hold in to make sure we had plenty of surface area of the implant. Since I couldn't go wider, I decided to go longer. Now, the one downside to this was at this time, I did not have 13-millimeter drill stops for the Sicat guide. Now, this Sicat guide was actually done in a classic fashion instead of the Optiguide. Now, the Optiguide, as some of you know, is done where we just take a digital scan and we incorporate that into the Galileo software, and that digital scan is then sent to Sicat through an FTP site. You don't need models. There's no hardware to send with, and there's no bite plate. Everything is done digitally. They do a 3D printed guide that has the tubes in it, and they send it back to you. This case was actually done with a classic guide. Now, the classic guide is a typical bite plate style guide, It has the bite registration material in there to help orient it. And then I just told them again I wanted 2 5-millimeter tubes for the Nobel BioCare inserted into my classic Sicat guide. Now you can see I went a little excessive on the resin cement. I wanted to make sure these things didn't move, so I pretty much glued them in with everything but the kitchen sink to make sure they weren't going to budge. And you can see with the 2 guides, we're right next to the lateral on the left side. The guides are butted up right against it, so we didn't have a whole lot of room. So a 4.5 would have fit buccolingually, but medial distally, there was no way I was going to get a 4.5 in both locations, even if 4.0 was pushing it. So the choice to go with a 3.5 was actually the best situation we could hope for here. And because we're going to a 13-millimeter implant, we have plenty of length to work with. So we go ahead and flap, and as you can see, we went ahead and we flapped the tissue back. And here's a situation where the guide will actually hold it out of the way. I'm just holding it out to get a better clear picture. Now, once we have it flapped, we can then visually see, because the guides are clear, exactly how much position we have over the bone. We can actually see what's going on in the anterior. In the posterior, you're not going to get this advantage because you're not going to be able to see it as easily. But in the anterior, when it's flapped, I can see exactly what's happening underneath the guide, which is very handy when you want to make sure you're going, that you don't have any fenestrations. And so then we go in and we, again, irrigate heavily. In a situation like this, I will also have my assistant irrigate with sterile saline coming from the other side just to help flush the area out and keep everything nice and cool. I do that with any system. I was doing that prior to using the direct cut, so I really have not changed my protocol in any way, shape, or form as far as irrigation methods go. The irrigation method for the direct cut drills is the same as what you would use for a regular drill. I just happen to always try to use double irrigation. And as you can see, we've got our direction all verified from our, and then there's our final placement. Now, as you can see, we had it nice and everything is nice and parallel. We've got plenty of distance between the implants, between each implant, and we're sitting right at about 1.5 millimeters between the lateral incisors. This case went very, very smoothly. The whole surgical process for this case takes about, this one took about 5 minutes, start to finish, from the actual drilling portion. And the reason for that was as I drilled in with the 11 millimeters, that got my initial depth. I then had to finish the 13 millimeter depth by hand. But 90% of my osteotomy has already been performed. All I had to do is go just a little bit deeper with the osteotomy to actually get it to seat completely flush to the bone. At the end of it, we did have a slight fenestration, so I did end up having to graft over the top of that, and that's why you see cover screws here. I got plenty of primary stability, but I had to graft at that time. I was planning on putting on some temporaries at that time, but however, it was not feasible to do so because of the grafting that I had to perform. Are there any questions so far?
No, there aren't currently any questions. If there are any questions, please enter them into the chat box in the bottom right of your screen.
Because that pretty much concludes the cases I had. So if there aren't any questions, we can go through the whole process. If there's any questions regarding the process, like I said, I've done, I don't know, probably 20 cases this way now, and it's become a very, very straightforward system. The patients are kind of amazed at how quick and easy the process is for them, and it makes for a very, very profitable situation. With the guides and the single drill protocol, it's very, very easy to do these. I do a lot of my implants now as just a side chair. I don't have to even block out main captive time anymore because the process is so straightforward. And the accuracy, as I showed with that first case, you can slide this right up against the sinus cavity and use it to actually help create your sinus lift, which I have done in situations where I have a short implant, where I have very minimal bone in the sinus area. I will place maybe a 10 millimeter implant, but I plan for a 6 millimeter implant right at the sinus cavity, and then I will drill down to depth, take that out, and then now my sinus lift is, I've already drilled into the sinus floor a bit, I can then just bump that up very, very simply.
There's a question that just came in. If you use the one-cut drill only if it's a 4.7 millimeter implant?
Let me clarify. So if you're using a 4.7,
basically, can you use the one-cut system if it's a variety of different widths?
Yes. Yeah, I've used it on the 5.0s, I've used it on the 4.5s, I've used it on the 4.0s and the 3.5s. I've used it on every single kind of conus 12 there is. And the direct cuts are now available, if I'm correct, Michael. They are available for all systems except the Straumann compatible, correct?
Yeah, that's correct. That just came in. If the sinus bump is accurately measured, that you discussed previously.
Is the sinus bump accurate? Yeah. I mean, what I'm looking at is so if you're talking about the first case I did, I just laid it right against it was just the lateral portion of the implant that was going to actually engage in the sinus floor at all. So when I thinned that out, then as I torqued the implant out, and it just lightly infractured that a little bit, and then that bone just heals right over the top of it. So I basically got bicortical stabilization. I just infractured a small portion of it as I torqued the implant into place. As far as the sinus lift, when I'm doing, say, a crestal approach sinus lift, and I've only got, say, 5 millimeters of bone, I will place the 6 millimeter implant 1 millimeter right at the floor. So there'll be a millimeter of implant sticking above the sinus, above the osseous crest. And so what I'll do is then I create my surgical guide based on that, drill down to depth, which means my drill stops right at the floor of the sinus, or even slightly, thin out that bone a little bit. Then I go in with either my piezo surgery unit, which I use, or you can go in with osteotomes and just tap that up and then place your bone in accordingly. And that allows you to drill. You don't have to drill. You don't have to try to find your markers on your drills as you're going. You have a direct stop that stops you, so there's no drilling and putting just a little too much pressure, and oops, you just hit the membrane and tore it. All you have to do is drill right to depth, and you're not going to you're not going to impinge on that membrane at all. You've drilled it down right to the sinus floor. You just have to then thin that bone out if there's any more to thin out, and then infracture that sinus floor up to create your sinus bump. Does that answer the question?
Yeah, it definitely does. How do the direct cuts behave in D1 type bone?
D1 bone is going to be a little tough. That's why I use a pilot drill to break that cortical plate. If you don't use that, or even just a round burr just to break that cortical plate, they require a lot more pressure to try to get through that cortical plate. But once they're through the cortical plate, they drill just fine in D1 bone. I've used it for overdenture cases, and once you get past the cortical plate, it just drills like normal bone.
Okay. Is the drill stop dependent on the make of the contra angle to work, or is it glued to the shank of the osteotomy former? The drill stop is attached. It actually comes off. It's not a permanent fixture onto the drill. It just slides right over the shank. Now, it only works, as far as I know it works on the W&H handpiece, and it works on the Blue Sky Bio handpiece. Other handpieces, I don't know. The depth will still be controlled with the drill. It's still the same, but what happens is if you put it on the drill stop onto a handpiece that doesn't work with, it won't slide in all the way, because the shaft of the head piece is too long, or you'll end up having it engaged and there'll be extra sticking out depending on the size of the head of the contra angle. It's dependent on the diameter, or the overall size of the head of the contra angle, whether or not the drill stop will work with that particular drill. Now, I know it works with the Blue Sky and it works with the W&H because those are the two that I have in my office. Right. Well, even W&H have recently come out with variations of their handpiece. So we recommend using the Blue Sky Bio handpiece to make sure that everything's compatible with each other.
And between the drills, the drills, the handpiece, and the implant, you're still into it, especially if you're just starting out in guided surgery. Guided surgery kits get to be extremely expensive. It's very easy to drop $10,000, $15,000 on it. If you get the Blue Sky Bio handpiece with the implant and the drill, you're still into the whole thing for under $500. Because actually, your drill's not even that much.
No, it's much less.
Yeah, that's including
$390.
Yeah, so you're $390 for the drill, $140 for the implant with the tube, and
$290.
The drill is $7. got $290 for the drill, so you're under $300 for the drill, $140 for the implant with the tube, and then $76 for that particular drill. So you can try the system out for less than $400 or right around $400. Between $400 and $500, you can try it out and see if you like it, which is really nice. It also gives you a backup handpiece, because I know that's always my glitch is I don't have enough handpieces ever running around, even with regular dentistry, let alone implant dentistry. Just when I need a second one, it's not available. So it's nice having that extra handpiece around anyway. But the old W&Hs do, but if they've got other models now, I mean, I've got the same implant handpiece I started with 5 years ago, and I've got the Blue Sky Bio, which I got last year, which is a great handpiece. It worked beautifully, and you really can't beat the price. So for those starting out in guided surgery, it's a very nice way to go.
I think the final question that came in now, if you have to be concerned that the pressure damages the D1 bone if not irrigated properly, since irrigation is a problem in guided surgery.
Not really in this situation, because again, as long as you pump action through it, the only tough part with the D1 bone is getting through that cortical plate, and that's any cortical plate. Even in the D2, D3 bone, you still have that dense cortical plate you have to get through, and that's why I like to use just a little guide drill or a round burr to just punch a hole in there. Just makes it easier. It'll get through there. You just have to let the water do its cooling action, and because the guide actually has the open wings on the side, it's very easy to get water. It's actually easier to get water in through these than it is to get it in through, say, like the Facilitate kit from Astra or the Straumann guided surgical kit. Those are a little more, they don't have quite as much leeway in them, so it's harder to get the water to flow through and hit that drill. But as long as you're bringing the drill out a little bit each time and allowing it to cool for a second and then reapplying it, you're fine. You don't just push it in and bear down until the thing stops. You're gonna hit it, drill a little bit, bring it out, let it cool, bring it back down and cool. And again, if you're really concerned about it, have your assistant with some chilled water, some chilled saline, and hit that from the side. That you saw in those, if I can go back, let me go back to one of my surgical guides. Like if you look at even this surgical guide here, you've got some venting around the laterals, but if you look at like the premolar one I did up here with the guide in place, it's very easy to get water through those vents on the side where you can see the teeth coming through, or even from underneath the guide. So if you have your assistant squirting some water in there, and again, you've got extra hands here because you don't have to be holding keys and reflecting and everything else. She can be doing something of that nature if you need her to. So if you're really worried about it in really dense bone, have your assistant have some chilled saline and shoot it in there. Again, from the side, from the lingual, from the buccal, doesn't matter. It's going to get through the various areas on the guide where you can see through.
Are these drills single-use drills?
No, they're not. You can use them multiple times. As a matter of fact, mine still haven't gotten dull enough to where I'm worried about it. I've done probably 20 cases with them, and they're still cutting like they were the same day. Because of the topography, again, they cut so well, they're not single-use, and that's one of the other beauties of it. You look at the Astra drills, and a single use of that, it starts to get really expensive, especially when you're doing sequential drilling. You've got two or three drills supposed to be single use, and then that actually is what got me started. When this came out, the single drill, back when I was doing Astra, the first time I did a guided surgery with the Astra Facilitate drills, the drill went in and it cut so fast, I was a little concerned. And I thought about, if we're doing this, why are we even bothering with sequential drilling? Because I'd seen the studies on the cooling aspect. And then in working with Blue Sky Bio, in their conus system, they developed these BioCut drills to do the single drill. And they're sharp enough, and the metallurgy is such that you don't have to worry about them. I mean, what's the recommendation on it, Michael, for actually reordering? When do you need to?
They're designed to work like a standard drill in terms of reordering. They're not designed to be single use, and they should last as long as any other drill does. Yeah.
So I'm up around, I think, 12 or 15 cases on some of these smaller sizes that I use more regularly, like the 4.0s and the 4.5s. I'm probably up around, the 8, 9 cases per drill easily, somewhere around 15 on probably the 4.0. And I'm probably going to get ready to order pretty soon because, again, at $76, even if you get 5 cases out of it, it's a lot cheaper and a lot more cost-effective than utilizing any other disposable system. And even with the numbers there, you're still talking better than the replacement drills. Because I have the Straumann kit, if I recall, to replace all the drills in that Strawman kit is like $600. Well, I can order a whole lot of $76 drills and reuse them a couple of times even, and it's still going to be more cost effective for me. And so if you are a doctor that's involved with insurance plans at all, and they're starting to cover implant placement, you're going to have to try to control your cost to some degree to keep that price, down to the point where you're going to get reimbursed at it, and to make it more feasible for your patients. And that's the beauty of working with a company like Blue Sky, where they actually keep the costs relative so we can keep our costs down and make it more feasible for the patients. And then when you increase your productivity, on a single implant case, it's nice, it's really quick, but what's really nice is when you're doing one of these on a 3 or 4 unit case. I had a maxillary 3 unit case that I did that the photography didn't turn out well, so I didn't use it, but the whole surgical time, it was an hour appointment to place all 3 implants guided. And most of that was flap management and doing the 2 sinus lifts that went along with it. But an hour for 2 sinus lifts and 3 implants, start to finish because I had these single-use drills and would just go, and they were all the same size, which made life even easier. And I just went in and did each implant, each hole, did the starter holes, and then just went down to depth on each one. So the whole surgical time for me for all 3 implants was 5 to 10 minutes. Then I had to do did my minor sinus lifts and placed my implants into place. So when you start getting into multiple implants, this process gets to be even better because it exponentially reduces your time, and the accuracy is still there, and it's a lot more comfortable for the patient.
Yep. Regarding the printed stops, what are they made out of, and how can I get them?
So they're just a plastic, and you can get them. You can get the download like I showed on this one here. If you look at the bottom there, you can see where it has the stops. It's downloadable. You can just download the .stl file. An STL file is just a common fabrication file used in any sort of CAD/CAM manufacturing. So it can be printed by any laboratory that has the ability to do 3D plastic printing. Now, if you go to the website, there are 2 laboratories that you can call, and you can get them done through them. I'll get you the names of those 2 real quick. It's at the bottom of the page. It is the 2 that they use is Road Dental Lab and Old Dominion Dental Corporation, and they can print those up for you. So if you're ordering, if you know this is a system you're going to utilize like I'm doing, I went ahead and I'm ordering, like I'm just getting ready to order some new ones. I'm going to order the 3.5s, the 4.0s, the 4.5s, and the 5.0s, and I'm going to order like 10 of each because they're about $4 a pop from Row, and I don't know what Old Dominion costs. So you're talking somewhere between probably $3 and $5 per stop, and you can either reuse them if you want. They can be sterilized. They start to lose their finish, and you can't read the numbers real well. But you can sterilize them; it doesn't distort them. And then, but they're also at a cost of $5, $4 to $5 a crack. You're still talking if you buy the guided implant at $140, you're talking a full of $145 of hard cost to place the implant completely guided. So, pretty much a disposable situation if you really wanted it to be. So you can order them, like I said, from either Road Dental or Old Dominion. And the numbers are on the website. If you go to the guided surgical section at the bottom of it, it'll say guided surgery stop STL files, and it'll talk about how to go through those steps for you.
Right. For each implant system, there's a guided surgery section that actually breaks down the implant, the drill, the guide tube, and the printed stop. So it's all organized according to implant. Yeah.
So you just go to whichever implant system you want to utilize and go to the guided system, the guided section, and it'll give you everything you need to know. It has the implant, the drill, and the stop that you would need. And that basically gets you ready to go. Whether you're using, it's the same for Sicat guide as it is for Sicat guides. So either way you go, everything is lined up for you there. You just order exactly what's there, and you'll be ready to start with that implant system. As long as you have a handpiece that's compatible, which again, with the Blue Sky Bio handpiece, it's easy enough to do.
Okay, I think that catches us up on the questions that came in. 1 second. How does it work on D4 bone? Would you drill to the size or treatment plan a size smaller?
Depending on the system, now one of the things I like about the conus system over the traditional Astra system, in D4 bone, you never wanted to go to the final drill because you wouldn't get enough primary stability no matter what you did. It was never that tight. In fact, I had problems with that for a long time until I talked to the rep out of LA, and he said, yeah, never go to the final drill in soft bone. Well, then why do we have a final drill? So, and you don't really need that hard bone with the Astra. So the nice thing I like about the conus system is it has some beefier threads on it. It has a little bit more engagement. So in soft bone, it depends on the quality. Even if it's really D4 soft bone, a lot of times, yeah, I will under prep it still, and I will press fit it if I'm looking to do immediate provisionalization. Typically, don't do that in soft bone, but usually I'll under prep it just a little bit. What I'll usually do is go to depth with that. Take out the guide, maybe just break the cortical portion a little bit, just enough to get the implant to go in, and then press and then torque that down all the way to depth and condense that bone out a little bit. So depending on the situation, but yeah, if it's real soft D4 bone, I'll usually under prep even with the blue sky. Even though it gives me better engagement, I still like to see that high number of insertion torque if I can.
And that's
any other
the questions that we have for
okay.
now. Are there any other questions?
All right. If you do have any other questions, let me get to the. Let's do this. This will be easier. If there are any questions, I'm going to put up my email address. Feel free to send me an email if you have any questions regarding the process. I'd be more than happy to get in touch with you about it. You can email me anytime. It's the easiest way to get in touch with me. I check email more. I ignore phone calls all the time, but I go to the side like I wanted to.
Let me point out that we have more information on the Blue Sky Bio website, including the studies that were referred to previously. And as well, we're available for questions.
So there's my email address. If anybody wants to get in touch with me, feel free to drop me an email. I'm more than happy to discuss this with anybody. I find it to be a very, very beneficial thing to do in your practice because it just takes a lot of the headaches. If you're not doing guided surgery, it makes life so much easier. And then the single cut, and it's really set for guided surgery. Don't try. I would not try to do these freehand. It doesn't. You can't control the guide path well enough. You're going to have to at least do some sequential drilling if you want to try to freehand with these direct cut drills. But for guided surgery, it's great. Your depth, your angulation, everything's controlled, and that takes care of any kicking of around roots or making sure it goes in the right path.
A question that just came in now, are these guides done with the scan appliance models wax up, or are they digital only?
You can do it off of a model, but so the case that I showed with the 2-unit case in the anterior, that was done off of models and the scan plate off of the Galeos or the XG3D. So if you don't have, you can still use this. You don't have to use the CAD/CAM portion to do a digital model. You can do it all with stone models. You take an impression, you take the scan with the bite plate in place, and then send all that off to Germany with the data from the Sicat or from the Galeos burned onto a disk. So you don't have to upload it if you don't want to. You can send it all through snail mail like we used to. So it doesn't have to be done digitally. You can do it with stone models and the bite plate, and then you just burn the information to a disk from your Galeos, and you still export it. You just use a classic guide as versus the Optiguide, and then you can send it all via FedEx.
Okay, and I'd also like to point out, although the presentation was focused on CEREC and Sicat, the Blue Sky Plan software could be used to treatment plan the case. We have a variety of labs that can make the guides, could send you everything you need with the guide. You could get the drills from the lab. You could get the printed stop from the lab. and you could have the metal tube fastened directly into the surgical template if you like. So that's an option as well.
Yeah. Yeah, and that's the thing. This was strictly about Sicat because that was asked me to do, but it can be done with any software and any CT scanner. And the process is the same. You're still going to order the same tube. You're still just going to put it in whatever guide you're using, and you can go with the, like you said, the labs will just have the whole thing ready for you. So when you get the guide, you don't even have to put the parts together anymore. It's all ready to go.
Right, and if the guide's being printed, they could print out the stops for you as well and send the stops together with the guide.
So you can have the whole thing as kind of an a la carte kit to just get from the laboratory. Now, which lab would you be using for that, Michael? Using Legro or Old Dominion for that?
Well, we have a list of certified labs that are making guides via Blue Sky Plan, and we really recommend any of them that are listed there. They've all undergone proper training and education to do that. Rose is a great option, and there are other good options on our website as well.
Okay.
So the more information exists on our website, and we hope to have a recording of this webinar available in a few days. And if there aren't any other questions, then I'd like to take this opportunity to thank Dr. O'Brien for this webinar and the presentation. I think it was really great and informative.
And thank you guys again. Oh, I'm sorry. Go ahead.
I'd just like to thank everybody for attending. We really had a great turnout. And the webinar, I know before we scheduled it, it was requested by many different dentists, and I think the turnout that we had tonight really reflects that. And the presentation was great. It really was phenomenal.
All right. Thank you, guys. Thank you very much for having me. And like I said, if you have any questions, don't hesitate to give my email a buzz.
Great. Thank you, and happy holidays to everybody.